Welcome, everybody. My name is Andy Oxman, and I'm a researcher at the Norwegian Institute of Public Health, and I'll be facilitating the discussion today. Um, I'd uh, to get started, let me first introduce Tammy. Tammy, do you want to introduce yourself?
Thanks, Andy. I'm Tammy. I'm Professor of Clinical Epidemiology at Bond University, Gold Coast, Australia. And I'm going to be keeping an eye on the questions as they come through tonight and asking the panelists.
And then I'd like to introduce Tom, who's our technical wizard, who's going to be holding our hands as we have this discussion. Tom, do you want to orient
Andy.
people?
I'll try my best. Yeah, so I'm here just to give you a little bit of housekeeping about using the webinar stage. I'll be quick. Just to say for attendees that the chat box will be closed, but you're encouraged to ask questions using the Q&A option in your menu. So if you just select that menu or the button from the menu, and then you put your question in there, and attendees can upvote other people's questions as well if they click on the thumbs up beside the question. There's the option for live transcription. So if you want to click on the button on your menu called live transcription and it's got a CC logo, and here you can request to have the transcription enabled. And the chat will be closed to attendees, but if you're having difficulties, we'll put my email in the chat box and you can contact me there. So that's just a quick housekeeping from me. Back to you, Andy.
Thanks, Tom. So now it's my pleasure to introduce the discussants for today's discussion. Pamela, would you like to go first?
Sure. Hello, everyone. I'm Pam Brunskill with the News Literacy Project in Washington, D.C., United States, and I'll be talking about an online lesson called Be Health Informed.
Thanks. Sarah, would you like to introduce yourself?
Hi, everybody. I'm Sarah Rosenbaum. I'm based in Oslo at the Norwegian Institute of Public Health with Andy. We're at the Center for Epidemic Interventions Research, and I'm a designer and a researcher, and I'm going to be talking about the Be Smart About Your Health project. Thanks.
Anka?
Hi, everybody. My name is Anke Steckelberg. I'm based in Halle, Germany at the Martin Luther University, and I'm talking about the project EBM at School.
Lila?
Hey everyone, I'm Leela. I'm a doctor working on a PhD and I am affiliated with the Institute of Evidence-Based Healthcare at Bond University in Australia. And I will be speaking about our intervention titled Health Hack, which is how to assess claims critically.
Thank you. Alan?
Hi everyone. My name is Alan Sanji, and I'm a researcher based at Makerere University College of Health Sciences in Kampala, Uganda. And I'll be talking about the Informed Health Choices Project resources for primary school children.
Thanks, Alan. And last but not least, Declan?
Hi, everybody. My name is Declan Devan. I'm a Professor of Health Research Methodology, University of Galway in Ireland, and I'll be talking about schools teaching awareness of randomized trials. It's the START competition.
Well, thanks, everybody. Tom, can you launch the poll now? Unfortunately, we can't engage all of you in the discussion, but we thought it would be nice to just share a bit of information about who's listening and hopefully asking questions and commenting as we have the discussion, including where you live, your professional background, and what you're hoping to get out of the discussion. Tom, will you share the results, or do you want me to do that?
So the poll is just open there now, so hopefully people will be able to put their answers in. There we go. Now people are starting to put them in.
It's a bit unfair. The time of day is much more suitable for Europeans than it is for Australians and Americans.
We're just at the 68% mark now in terms of people who've filled out the poll, so we'll give them another few seconds, see if we can get to the magical 100. Nearly there. Okay, I think it's staying stubborn there, so I'll end that poll and share the results. Hope everyone can see that.
Yeah. And the professional backgrounds?
If you scroll down, I'm not sure if you can see my screen. Yeah.
Got it.
And then what did you hope to get most of the discussion?
It's a nice mix of people from health and education. It's great. And a mix of motivation. So hopefully we'll meet your expectations as we go on with the discussion. So let's get started. I'd like to start by just getting a sense of where the ideas for these 6 projects came from. What was the motivation? Pamela, maybe you can go first and say a little bit about be health informed, and maybe a bit about how it's similar or different from other Czechology lessons, since the rest of us work in healthcare, whereas you're coming from the world of media literacy.
Yeah, thanks. So Be Health Informed is one of our offerings on our Czechology platform, which is it's just an online space where it's free. So we have a public version and an educator-facing version, and teachers can sign up and register their classes. And we currently have 18 different lessons on our platform. And at the beginning of the year, we realized, well, we had already known that we have a lot of offerings for ELA and social studies teachers. And we're meeting a strong need there for the news literacy aspect of ELA and English language arts and social studies. We had a lot of different lessons like what is news? What makes news? Is it timely, important, interesting, unique? We have standards of quality journalism. We have lessons on the First Amendment and press freedoms, right? But we didn't have a whole lot of offerings for science educators. So we wanted to create a series of STEM lessons: science, technology, engineering, math. And one of those is our Be Health Informed lesson, which deals with, creating, understanding health and wellness information, specific research behind health claims and what makes quality research, and then some red flags you can look for. So we just recently launched this in the last few months, and that's where this idea came from. It was we received a grant from the Science Literacy Foundation to develop it, along with some other funders, and we got some really quality people on board. Started reading about what are the who are the leaders in this field, and that's where we connected with Andy. And Andy was on our advisory committee and helped us steer into what articles and people we should be reading, and gathered more people on our advisory committee and developed our script. So now we have this lesson called Be Health Informed on our Czechology platform. Andy, you're muted.
There you go. Thanks. Anke, I can guess where EBM at school, where the idea came from, but can you say a little bit more about what motivated you to do that?
Oh, yes. Actually, in the end of the 90s, we started to develop evidence-based patient information. And well, we knew it was challenging, and the aim was to allow informed choices and to provide patients with information so they can make informed choices. And at that time, we knew that our approach, like we would approach a rather illiterate public. And the first decision aids we developed, they were rather textbooks. We saw that we had to explain lots of things like about diagnostic tests, about where does the information come from, about randomized controlled trials. And that actually brought us to the idea that we need trainings, teaching for the public to prepare them to use this new kind of information. And actually, we started with adults, with our first trainings. And after that, we thought, well, actually, everybody should be provided with a certain amount of health literacy. And that was the motivation to start the project EBM at School that addressed secondary school students.
Great. How did you decide to start with secondary school students rather than adults?
Well, actually, with our backgrounds, we were educated to rather teach adults than students. And so we started with the adults, and then we thought we started with the elder students in the secondary schools, because we thought first we want to show whether it will work with the older students, and then as a next step we would address the younger ones that like in Germany, students leave the school system with grade 10, so we would actually try to approach them before they leave the school system.
Thanks. Leela, you want to tell us about Health Hack and how you got started on that?
Yeah, no worries. So I guess there's several reasons. I guess the most obvious one was that we were concerned about misleading health claims that people were regularly exposed to. And we noticed that there was some challenge engaging patients with shared decision-making in consults. And we recognized the need to give education skills earlier in life to help with these, informed health decisions, because kids in high school are starting to make decisions about their health, even simple things like energy drinks and skin creams and so on and so forth. So we thought the best way to reach a lot of young minds would be school. So our intervention is for high school students, and the content of the intervention was informed by a systematic review. So this was a review of all the studies that had evaluated interventions that aimed to improve the understanding of the key concepts needed to appraise health claims. And this review found that such interventions can improve knowledge and skills. And it also identified gaps in existing interventions. And we looked at also a qualitative study which explored Australian adolescents' understanding of health claims and health decisions, which helped us to really focus on topics that were most needed in this population in Australian high school students. So we developed a rough draft, and I guess this is less about the motivation, but just about the development itself. We then took it to an advisory panel to get feedback from educators to get their input, and we also sought feedback from students within the target age range. And then we went back, made some changes, and then we piloted again with 2 classes and again within the target population, and got some feedback, and then we developed the actual intervention, and that was what we used, and just finished an RCT on that as well.
Thanks, Leela. Declan, you want to tell us how you got started on START?
Yeah, I think the idea. So START is an initiative that challenges primary school kids between the ages of about 8 to 12, with the support of their teachers, to design, conduct, analyze, and report their own randomized trial. And the genesis idea is that our group includes a number of initiatives, including Evidence Synthesis Ireland and the Health Research Board's Trials Methodology Research Network, which has, and the HRB Trials Methodology Research Network has a an objective to increase public awareness and understanding of randomized trials, and START is one of those initiatives that we kicked off to try to increase that public awareness and understanding of what randomized trials are and why they are important. Why children is a good question, but we thought that starting with children for a number of reasons. I think number one, we thought it'd be good fun, frankly, and it has been great fun. Number two, that if we could work with children and their teachers to increase the awareness and understanding of randomized trials and demonstrate that we could do that, then we probably had a better chance of doing that with an older public audience. And then the third reason was the potential for the initiative to provide a teaching vehicle through which teachers could help children think more critically. So increase critical thinking. And the evaluations we've done have shown that that has had some success. So that was the genesis of the idea, Andy.
Great. How did you decide on making it a project where kids would do the project and then you bring them together as opposed to getting things into lessons?
It's a good question. The ideal way would be, for of course, that we have it integrated that critical thinking within the lessons themselves. But it's certainly in our country, it's a big ask to change the curriculum as such. And teachers have a lot of latitude in how they deliver aspects of the curriculum, for example, in science, but they've told us, absence of tools that might enable them to deliver science in a different way, or in a way that does engage with critical thinking around various aspects of the curriculum. So one of the things we learned very quickly with START that we've got to present this as something from the ground up that teachers want and need, and that can meet a need within the curriculum. And I think that's one of the reasons that we've chosen to bring it the way we have. We do know that now that some teachers are using it as a teaching tool for science. Children have told us, ironically, the children have said, for example, when colleagues have evaluated this, including Tom and a colleague, Linda Beastie, they've said, kids have said, it's not science, it's fun, which perhaps, says something about how we sometimes teach science to children. But it seems to have given a vehicle whereby teachers can engage and work with the children to start thinking a little bit more critically around questions that they might have, and try to come up with solutions on how they might develop a process to answer those questions.
Thanks, Declan. Alan, you want to tell us about the motivation behind the Informed Health Choices primary school resources?
Yes, for the Informed Health Choices primary school resources, it started out with researchers in evidence-based medicine that had both personal and professional experiences where people were not applying evidence in drafting health policies, as well as not applying evidence when they are appraising health information. The earlier initiative started out with engaging policymakers and journalists or the media, trying to come up with initiatives that sort of engaged or enabled them to use evidence to communicate as well as to draft policies. That didn't work very well. And as a result, they did decide that we needed to start with maybe getting the basics right, and that involves sort of getting the attention of primary school children, and the fact that those do tend to have the time to engage with these resources or initiatives, but also they have a wide sort of range of experience in terms of when they do learn these lessons, but also the time they start to apply. So we thought that the experiences they would gain in using the materials that we developed would be very helpful. And at the time, if these children do end up becoming the policymakers of the future, they'll be able to automatically apply evidence when drafting policies or when communicating health information if they end up being journalists. But that has ended up in us developing lessons called the Informed Health Choices lessons, about 10 lessons for children between the ages of 10 to 12 in grade 5 or primary 5 here in Uganda. Thank you.
Thanks, Alan. And Sarah, do you want to say how the secondary school, Informed Health Choice secondary schools got started?
Yeah, well, the Be Smart About Your Health project builds directly on the project that Alan was talking about. And the evaluations from the primary school resources show that intervention, which was a book for students and a teacher's guide that were printed materials, those were they were useful and well received and had effect, but they were expensive to print, especially in the context of low income settings, and also we had developed them without looking at the how they might fit into the curriculum. So in our next project, when we decided we wanted to look at how we might develop resources for an older age group, we specified in the beginning of the project that they would be digital resources rather than printed resources. And we used the same framework of concepts that the primary school resources drew from. It's a set of key concepts for teaching people to think critically about claims and make informed choices about health interventions. And so we drew on a similar set of concepts for the secondary school resources, but developed them in digital format rather than print. So the way that we worked with that was to engage with a wide range of stakeholders, both people in, the project is placed in Uganda, Kenya, and Rwanda, and we drew on networks of teachers and students in those settings, and engaged with educational policymakers in those settings, and started off with a context analysis in each country, so that we understood better the limitations and the possibilities in each setting, how we might move forward and work with resources in a digital context. Yeah.
Thanks, Sarah. Tammy, have there been questions from the attendees, or do any of you have questions for each other about how you all got started?
Not yet. So please use the question and answer function down the bottom of your Zoom menu to post any questions you've got.
Great. One thing I'd like to follow up on is several of you mentioned theories underlying the work you did. So the theory of experiential learning and the inoculation theory. And I'm wondering how helpful those theories were in moving forward, deciding how to get started, and how you picked the particular theories that you did to inform your work.
So you mentioned inoculation theory, and that is a core tenet of most of our work at the News Literacy Project. And inoculation theory is basically it's similar to like vaccine, right? You expose people to warnings about the potential of misinformation or disinformation and tactics used to spread misinformation. And by giving people just little bits, it equips them with the knowledge and skills to recognize and reject misinformation when they encounter it in the real world. And there have been a few studies. I want to say, no, I'm not going to give a date here because I'm going to misspeak, but it's been around for a while. And a lot of recent studies suggesting that it is much more powerful than debunking, right? Because whatever we hear first sticks. So in the same way that we deal with medical issues and trying to inoculate people against diseases, this is the cognitive disease we're trying to fight at the News Literacy Project. But you also mentioned other theoretical approaches. So I just want to say, since we're also educational resources, right, they're standalone resources, so we can't exactly say how teachers should implement them. So as standalone resources, at least Be Health Informed is a cognitive theoretical approach, because it all depends on how students interpret it. But when I create my resources at NLP News Literacy Project, I'm always coming from an education background. I was an educator for many years, and my approach in the classroom was sociocognitive. So it's always that interaction between people as well as individual understandings of information.
Yeah, Tammy?
Okay, Andy, the questions are starting to come in, which is great. So one that follows in from your question, Andy, and it was about how the different projects use theory in their evaluations, so including the process evaluations and how useful this was. So this is open to any panelist who wants to talk about theories in the evaluations of the interventions. Any volunteers to answer that one? Was there a theory used in the evaluations? I should probably make a note of it.
I think there was a bit of a difficulty hearing the question, Tammy, just from a...
Maybe you can just repeat it.
Yeah, was there any, when you were designing the evaluation of your intervention, was there a theory behind the evaluation, including if there was a process evaluation that happened?
I'm not sure if I'm answering the question, but I'll have a go at it. So why stop now? So in terms of theory in the evaluation, so as I mentioned, there was an evaluation, qualitative evaluation done of the START initiative by Tom Conway and Linda Beastie and others, and that used a qualitative approach, and there was and that adhered to the processes within a qualitative research study, and the data collection methods were one-to-one interviews with teachers, focus group interviews with kids, etc. And there was a particular looking at template analysis, for example. But in terms of so qualitative research would have its own theoretical perspective, obviously, and that was that interpretive approach was which was what informed that qualitative design. But I'm not sure if that answers the question. But so for the evaluation of the START initiative, it was an interpretive theoretical perspective that informed a qualitative research design.
Thanks, Declan. Anyone else has comment? Sarah?
Yeah, I can. I'm not. I only have a minor role in the process evaluation of the Be Smart About Your Health resources. There's other members of our team that have been leading that work, but and I'm not sure if it qualifies as theory, but we drew up a logic model to design the process evaluation questions. And we designed the evaluation about exploring dose and reach of the intervention, and also to what degree it was adapted by teachers underway. So the logic model is in the protocol for the process evaluation, which is available on the website, the Informed Health Choices website. And so if people are interested in the details around that, they can download that document and take a look at it.
Thanks, Sarah. And Anka, you've got your hand up.
Yes, when we started to develop the intervention, we thought about how could we evaluate this intervention, and parallel to the development process of the intervention, we developed an instrument, the critical health competence test, to evaluate our intervention. That's what we did for quantitative evaluation, and parallel to that, during the intervention, during the pilot tests, we had we had focus group with the students, we had interviews with the teachers, and we followed a qualitative content analysis approach to analyze the data. Because like we did, the first thing we did is we had pilot studies, so we more needed the qualitative data than like the quantitative approach that was more for exploration.
Okay, thank you. Does anyone else have anything on that evaluation theory? No? Okay, we might move on. There's quite a few more questions coming in. There's two that are about impact. So again, this is for anyone who'd like to answer. One is just how did you assess the impacts of your projects? And a related question is what's the reach of the projects and numbers? And I presume that's views or downloads or students taught to date. So we might, I think everyone's probably got a response to this. We might go around everyone in turn. Shall we start with, might start with Sarah. Sorry, Sarah, I put you on the spot there.
It's okay. Yeah,
so can I just add to this question, since we're moving on to a new topic? It would be very helpful if you could each think about, from what you learned, what you would do the same if you were starting over again, or what you would do differently, given what you've learned from implementing and evaluating your interventions. Sorry, go ahead, Sarah.
So do you want me to comment on what you just asked, Andy, or should I?
I think they're pretty much the same.
Oh, okay. I was preparing to sort of just tell a little bit about how we
start with Tammy's question.
Okay. So Tammy, your question was, how did we evaluate the effect of the research?
How did you evaluate impact, and then do you have any idea of reach, or so how many students have you reached or intend to reach?
Right.
Today.
So the development of this intervention was in the context of a research project, and so we evaluated actually. I could say that we also evaluated during development, because we carried out quite a comprehensive development phase that lasted for about a year and a half, where we iterated the intervention and made changes based on feedback that we collected underway. But so that's probably not the kind of evaluation people are wondering about. We've just conducted 3 randomized trials, one in each of the countries, and we randomly selected about 80 schools in each country and assigned them either to the intervention or to no intervention. And the results of that are still pending, but we have preliminary results that look quite positive. And the outcomes that we were looking at were the difference between the intervention group and the control group, the scores of the students. And then we had some secondary outcomes, which were the number of students with a mastery score as opposed to just a passing score, and the average score across the group of students. And let's see what else. Andy, what was your question about? What would we learned and what we did differently?
Yeah.
Yeah. Well, the methods we used to develop the resources helped us to discover problems early on and make changes. And we did 3 full iterations of our intervention. The final, we did a full pilot for a whole school semester prior to the trial. And so we would definitely continue to use that type of development method in any new projects, because you never start out with the right idea. You usually start off with an idea that's not going to work very well, and you need to iterate in order to come to an intervention that actually is suitable for the context that you're meaning for it to work in. And some of what we learned was that we were trying to use computers in classrooms, and students using computers in classrooms and developing an intervention that could work, a resource that could work that way. And what we found out was that even in the schools that had sufficient computers for students, it wasn't a very good combination. Trying to teach critical thinking, which involves a lot of discussion among people, and inserting a computer into that context. The modes that we ended up developing the resources in 3 different modes: one for classrooms with computers for students, one for classrooms where just the teacher had a computer and used a projector, and one for classrooms where there were no computers and the teacher only had a mobile phone. And we found that the lower tech modes of these resources seem to function better for lots of reasons. And so I think that that moving forward, we might continue to look at the lower tech modes of delivery, that maybe those were more suitable for prompting discussions and exchange of communication between teachers and students. One of the things one of the team members mentioned that we might do differently in the next round would be to involve parents to a larger degree while developing the resources, but maybe also as end users develop resources that could also be used towards parents as an end user group. And let's see. I'm sure I had other things written down about things we would do differently, but I'll think of those and let somebody else talk.
We might do a roundup at the end anyway, Sarah, if something else comes to mind. Alan, you put your hand up. Did you have comments about either the reach and the impact, how you'd measure impact, and or what you'd do differently?
Yeah. So in addition to what Sarah has just said, so initially we started out with the primary schools. That's where the Informed Health Choices projects were initially evaluated. We worked with, of course, using a cluster randomized trial design, we worked with about 120 schools that had a population of about 20,000 students, but not all of them were able to do the evaluation at the end of the term. The development was also done within the different primary schools in this context. So it's very difficult to know exactly how big the reach was, but going by the numbers, I think it was a very significant one, because if you put into consideration the different schools that participated in the development of the primary school resources, in addition to those that worked with us in the development of the claim evaluation tool, plus those that participated in the evaluation. So it was a significant number. Unfortunately, we're not able to put a number to it, but from the process evaluation interviews that we've carried out while we're doing the secondary school resources that Sarah was talking about, we still see that impact in the students that participated in the primary school resources who are currently in secondary schools and have been sort of either part of the development process or may have been part of the groups that participated in the evaluation. Those results are not yet out. When it comes to what would do something that would sort of be the same if we had to do this again, I think the impact of including stakeholders in the development in a context where such resources are non-existent was significant. I think children's contribution as well as teachers' contribution enabled us come up with a tool that's not only found useful, but also enjoyable, but also adaptable or adaptive to the context in which it was being evaluated. I think that was very important. And I think that's something that we'll definitely keep doing in case we ended up doing this again. I think what we would do differently when it comes to coming up with materials for the interventions that we've done or developed, we focused on one grade or one sort of an age group of say 10 to 12. I think it would be very, very helpful if we came up with materials that sort of cover the whole primary school cycle. Probably we start out with small concepts and being introduced maybe to a younger age group, and then we build up on that until children are out of the primary school cycle instead of focusing on one age group, which is primary 5. That I think is best or related to the high school dropouts in the context in which we are working on. If someone is not able to go as far as primary 5, they would have missed out on learning these very important concepts. I think that's what we'll be doing differently.
Thanks, Alan. No, who hasn't? Layla, you haven't spoken for a while. I guess just to point out a few housekeeping things before I forget, I think most people here are talking about, in terms of reach and impact, they're talking about the sample sizes in their studies, in their evaluation studies. So that's a nice reminder that on the Informed Health Choices website and at the top of your chat, Andy's posted a link to a PDF of tonight's roundtable discussion, which has a brief summary of all the interventions and sort of how long they went for and what topics they covered and format and things like that. And also, so if you want to go and look up more information about any of the interventions, right at the top of the chat, Andy's put the link on the Informed Health Choices website. And also just to deal with a few questions that have come up. Anyone who wanted a copy of the critical health competency test that Annika mentioned, if you email her, she will send you the PDFs of that. So later, so back to you. On to anything to do with impact or reach. As I said, we're talking at the moment about, I guess, mainly sample size and number of students reached. Later in the webinar, we will talk about implementation and scale up. So sort of save any comments for that for later. But at the moment, what we've done so far.
All right, so this was developed as part of my PhD project, and we evaluated the impact of the intervention through a cluster randomised controlled trial. We recruited 9 Australian high schools in 2 Australian states with a total of almost 1,000 participants. So I guess you'd say the reach of the intervention was under around half of that, because the other half were the control, although we did provide the intervention to the control group or the control schools and let the schools deliver the program if they wished outside of the study. So the reach, don't exactly know, but maybe around 1,000 students at this point. We are writing up the results at the moment, and ultimately the impact of our intervention is unclear at this stage. The results were not as ideal as we had hoped for a few reasons. We got some decent results, but also there were things we could have changed, and I guess that leads to strengths and weaknesses and what we would say could be done next time to ensure a better outcome. I think it can be a challenge to deliver through high schools. I think it can be both a strength and a weakness, because you're reaching a large percentage of the population, but it's also, we've found it quite challenging to actually get the program into schools, but that could have also been slightly to do with COVID and the fact that many of the schools were locked down during the period when we were trying to run our trial. So that could have been a huge factor, but also the timing of the program. Quite often it was delivered towards the end of the school term when students were less engaged and thinking about holidays, and there was no incentive there to motivate them to really focus on what was being done. What else? High school, the content, the feedback we also had. So next time we would probably, some of the feedback we received were about challenges covering all the material within the allocated timeframes and maintaining student engagement throughout the program. So what we would be thinking to do is to tweak the material with to help with the issues with sticking to time frames. So maybe give them a bit more time to work through the different activities and topics, and maintaining student engagement. Some of the feedback actually, well, the good stuff, for example, they loved Bad Science Bingo, which was one of the activities, and there's quite a few responses to that particular activity. So there was that particular activity. I would say maybe we need to focus on those types of activities because it stood out that much. And the other issue that they mentioned was the discussion points. We had included discussion points as a way to spark a conversation and to engage students so that they would, start critically thinking. But apparently the feedback we were getting was that it was actually disengaging students. I mean, not all the time, but some of these schools were feeding back. So we could potentially tweak the program, taking this feedback and then seeing what results we would achieve with these changes from this this time around, I guess you could say. So overall, we definitely could make changes, but the overall feedback was quite positive. The teachers said it was a really worthwhile, and it was something they would support, including into the curriculum. And the assessment, we actually struggled. I'm not sure if you want to hear about assessing the intervention, but I think it's very important that we do, because we do need quantitative assessments, because I think that's one of the challenges is to get this type of feedback so that we can convince people that this type of education needs to be in the curriculum. It needs to be, it needs to reach a large percentage of the population. That's what we do need, that reach. So I think one of the biggest challenges is to convince people that it's necessary, and to do that, I think we need the quantitative data. So if we can enhance this material, potentially we could go back and show some actual data to convince people that it's worthwhile. The only other thing I would mention is that we tried to do a pre and post assessment, and we were challenged with issues around the ID. Students created their own identification, and either through intentional or unintentional thoughts, I'm not sure, but we had trouble matching their entries so that we could match their data and really assess what was happening there. So that was a big issue that prevented matching a large proportion of data. So that would be something also to keep in mind, that you are dealing with students who may not be so driven to be helpful for whatever reason.
Can I just jump in here as Layla's supervisor? And we're dealing with teenagers who are not exactly known for always following the rules and doing what they're asked and playing nicely. So I think that's an added challenge with dealing with teenagers.
Yep, that was pretty much it. So perfect timing. Thank you, Tammy.
Oh, sorry, Pamela, did you have comments about either your numbers in your evaluation or the reach that you've been able to look at your impact?
Sure.
And
Yeah. So we at the News Literacy Project, we started small, and we actually had gone into individual classrooms and realized that was just not sustainable if we wanted to do a mass scale implementation of our lessons. So back in 2016, that's when we designed Checkology, and that's again what Be Health Informed is on. And for the last school year, 2021 to 2022, we had over 100,000 active students on the platform in just 1 year. So we have a pretty large reach, and we evaluate the effect of this program through a pre and post assessment. It's, I think, 15 to 18 questions. It varies each year. And given the number of educators actively using our resources, not just Checkology, we estimate we reached 2,461,950 students last year with all of our resources. So it's a massive, massive reach, at least in my view. And we assess our effectiveness of Checkology through independent assessment by 2 researchers who specialize in the field of news literacy. And our pre-post surveys showed that our Checkology lessons substantially improved student responses from multiple metrics. For example, the assessment showed a 34-point gain in the percentage of students who could correctly identify the 5 freedoms protected by the First Amendment. And I see, Shelley, you had asked me about how do we assess, what outcomes will you assess in our study? So these 15 to 18 questions all deal with 5 standards for news literacy, dealing with sorting information between traditional and non-traditional ads, information and other types of like sorting information from propaganda, opinion, advertising, entertainment. So that's our first standard. The next one is acknowledging the importance of a free press. the First Amendment in American democracy and a free press to an informed public. The third one would be understanding the standards of quality journalism and how we can use them to identify credible information and sources. The fourth one, and that's where Be Health Informed really comes into play, is demonstrating increased critical habits of mind, which a lot of you are also talking about, which is thinking critically. We at NLP talk about developing a healthy skepticism. We want students to be skeptical of the information they encounter in their world, but not be nihilistic and give up saying everything's bad, right? Like, we have to teach them the tools to evaluate what is credible and what is not. So to verify and detect misinformation and faulty evidence. And then our fifth standard is going to be, and this one's the hardest to evaluate, and we keep going back to how are we going to evaluate this, but we're trying to get students to express a sense of responsibility for the information they share and to feel more empowered to be civically engaged. And that's our big mission. That's our goal, is to have a populace that is civically engaged and news literate. We talk about, for those of you who are familiar with disciplinary literacy, we teach our students to think like journalists. And when they can do that, they know what is involved in quality journalism and what is not, and what is information and what is opinion. And when they're inundated with memes and anecdotal evidence, put in quotes, right, for this group of people, what is credible, and what should I believe, and what should I do with that information? Thank you very much, Pamela. Annika, you've got your hand up there. Okay.
Oh, we're asking Nia.
Yeah, sorry.
Yes.
No, my hand is up. Yeah.
Well,
I think, it was Anka. Sorry.
Yeah.
Yes, sorry, Andy.
Okay, well, we started off very small, and the idea was following the framework for the development and evaluation of complex intervention. We thought, well, we develop EBM at school, and we want to see whether it will work in this setting. And as a next step, we wanted to do a randomized controlled trial. But that was quite difficult. When we started with this pilot course, and the project EBM at School provides all the worksheets, all the material that teachers will need to teach this course. And even though we included teachers in our discussion in the development process, we saw in the interviews we did that even though, like, we provided all the material, and the teachers were science teachers especially, and they didn't feel prepared to teach this curriculum, because they said, well, I can use this curriculum, but what do I do when students have further questions? Like, they address very different topics. They said they were not educated to do literature searches and critical appraisal of new topics themselves. So what we learned during this process was that we have to prepare the teachers to teach this curriculum, and that brought us to the idea that we need to train the trainer concept. So as a next step, we applied for funding to do an RCT that included the train the trainer curriculum for the teachers, and we wanted to see whether those trained teachers would reach the comparable results than the experts in the trial. However, in Germany, we have a federal system, and it is actually, for us, it was impossible to get funding for this kind of RCT. The funding bodies, they don't really feel responsible to fund these kind of educational studies. So what we did, we developed such a train the trainer concept, and we have some teachers in just one federal state, they still they still use this curriculum and apply it to their students, but the outreach of our project therefore is very small, and we still try to get funding, but it's hard job.
Actually, on that, thank you, Anka. On that note, I might, if all the panelists, there's a question about ethics approval and funding. If you can go to the question and answer and perhaps respond to whether you needed ethics and had funding as you go. And lucky last, Declan, on this topic of reach and impact and what you do differently.
Yeah, Sarah had her hand up before me. I know Sarah wanted to come in on something, maybe, Tammy, or do you want me to go?
Sarah, did you have a question relating?
I actually raised my hand after Pamela was talking about, she was talking about how they want to avoid students being nihilistic, and it just reminded me that in our process evaluation, we're also attempting to find ways of evaluating potential adverse effects of this intervention. So, for instance, pessimism or distrust, a general distrust of, what can we trust, conflicts between what they learn at home or from their parents and what they learn in school, and other types of potential adverse effects. I just thought I would raise that we're looking at how we might evaluate that kind of thing.
Thank you, Sarah. Declan?
Thanks, Tammy. Yeah, in terms of evaluation, I've mentioned already in terms of our qualitative evaluation that we did. We do need to look at doing a trial, but we need adequate numbers of schools engaged simultaneously to do so. I can come back to that if there's time and if helpful. I think what we do differently, I think, is, we perhaps not necessarily differently, but we need to do better at the teachers are the experts at teaching the children, and we see our role is to support them with the tools that they might need to support participation in whatever we do, the START competition or other work we're doing with the Informed Health Choices program, for example. So I think we could do better with supporting teachers and that train the trainer that Alan's mentioned around perhaps providing some support for teachers in terms of to increase their own confidence and understanding in relation to, for example, informed health choices or randomized trials or trials as part of informed health choices, whatever it may be. I think that developing additional support for the teachers and for the children and providing them with different levels of perhaps scaffolding that might be needed may help. We very quickly learned when we started off our START initiative, which, bearing in mind, is in children designing, planning, and conducting and analysing, reporting their own randomised trial. We very quickly learned that actually our target audience wasn't children. Our target audience was teachers. Teachers for a number of reasons. Teachers, number one, to get the initiative into the schools. Teachers are the gatekeepers. Number two, we don't have the expertise that teachers have. We very quickly learned that. In terms of engaging with and supporting teachers, the intervention can only be effective or has only a chance of being effective if you've got strong involvement of the experts in teaching children. And so we've lent heavily on a small group of teachers persistently over the last number of years, for which we're very grateful for their expertise. So what we do differently, I think, would be just continue to build on the resources that we provide for teachers, so we better help them to support the initiatives within the schools.
Okay, thanks very much, Declan. I think it's probably time to shift gears and change topics. Andy, I'll head back to you.
Great, thanks, Tammy. And we'll try to continue to pick up questions as we go, but I'd like to move on now. And one question we may want to come back to that we've touched on during this discussion, but I'm not going to ask you this now. In addition to the point Sarah raised about adverse effects, another big question is how can we measure the extent to which students actually use what they're learning in their daily life? And do we know whether or not they are? And related a bit to the question about harms is equity. Are we reaching students who need this the most, and not just the brighter students in the class who have a better position to learn? So I'm just flagging that. But I'd like to spend some time now talking about the biggest challenges for getting your intervention specifically used more widely outside of the trials and what you're doing yourselves, scaling up the use, as well as facilitators, particularly in Pamela's case, and any ideas you have about how we or others can get teaching students to think critically about health, or for that matter, about other decisions into the curricula and get it taught in ways that are effective in schools. So I don't know, Alan, do you want to go first? And
Yeah, I think in our experience, what's sort of proven difficult is getting the resources into the primary school curriculum. I think some of the information that came out from the post-evaluation interviews was that it would have been almost as straightforward an issue if the concepts we're teaching primary school children were tagged to the primary school curriculum. Then ideally the schools would easily scale them up, which is not the case. So we're still working in collaboration with the Curriculum Development Center, see how we can get these resources into that primary school curriculum. I think the other challenge that we have faced in getting that done is that the primary school budget vote allocated to primary school children is very small. For example, it's about $30 per year or per annum for a primary school child. That's what the government allocates to them. And if we are going to use the particular resources that we used in our trial, which were printed materials, it would be very costly for the government to fund as little as $4 per child. But if you compare it to the $30 for the entire year, that would be a huge chunk taken out of the budget. So that's where we're facing challenges as well. But some of the discussions we've held with the policymakers have pointed us to forming collaborations with development partners. And those are, for example, NGOs or UN agencies that are interested in education, see if we can partner with them for us to be able to get those costs down and have those materials printed out and sent out to schools. I think the other challenge that we've also faced is how tight the primary school schedule is. That was evident way before COVID-19. Now that we've had the COVID-19 times sort of affecting how the school curriculum or the school timetable is scheduled, it's even tighter than it was before. You might be aware that we had the longest school closure, which was 2 years that the children were out of school. So they're almost playing catch up. And now to introduce something that they do not see as part of the curriculum is still becoming very tricky because they haven't stabilized in terms of having their schedules realigned from what they were before COVID-19 hit. So those are some of the challenges we are facing with scaling up our intervention, although it was found to be effective.
Thanks, Alan. Yeah, Leila, do you want to go next?
Sure. So we're talking about upscalability. Our materials, they're all affordable and accessible to most schools. Most schools in Australia have printers and have the ability to display PowerPoint. So when we were developing the intervention, we did keep scalability in mind. So not only the materials accessible and affordable, the regular class teacher delivers the intervention, and the teacher already has the established rapport, and this also ensures continuity within the teaching program. And the teachers require no preparation, which that can always be. My understanding of teachers is there's a lot of pressure on them, and that they've got their curriculum already set out. So
the additional requirement of preparation, removing that actually probably helps with the upscaling potentially, because it's less of a barrier, because, you know, we don't need the extra funding or the extra training, because they can just step up and use it. And that was actually one of the positive feedbacks, that every teacher felt adequately prepared with the materials that they were provided. So that was one of the benefit, I think, one of the important factors of scalability in our work there. And I guess, again, the biggest challenge for upscaling is, again, convincing whoever needs to be convinced that this intervention is necessary and that it's effective, and getting it into the schools. I think it's a similar issue as what Alan was just mentioning. And this is why we do need to work on the quantitative evaluation of the intervention. And our intention was always to get this program into high schools. But first we need to convince the high schools to get it in there, to get the quantitative data. So it's a bit of a challenge, and I'm not sure what the answer is, but maybe together we can come up with these great ideas.
Thanks, Leela. Anka, do you want to talk about your experience?
Well, actually, when we think about further implementation, I think we also have to have in mind that we want to implement these educational resources into a system where in parallel we have a healthcare system that is, well, that does not yet promote informed decision making in general. So like students that learn at school what kind of information is needed to make good decisions, they are also confronted with a healthcare system when they ask these questions with their doctors or in a hospital. They will probably not get the answers they want. So this is probably quite a barrier in further implementation, because like also the adults, the parents, they are socialized in this complex system. And I think we have to keep that in mind. So even though we might see promising results in our studies, in the long term, we don't know what really, what's the most influence on the decisions. Is it our curriculum, or is it like the system in general? And in addition, I think the COVID pandemic really is a good example to show that the public is confronted with information actually nobody can understand, and there's a lot of arguing with studies, and nobody really questions, are those the studies that answer these questions? So I think these questions of implementation are very, very complex, and we need all the initiatives in the healthcare system that we already have, but we even we are also confronted with a lot of barriers in implementing participation and informed decision making. It is, and like we know that one important barrier is the attitude of the experts in the field. We experienced, maybe I can give you an example, like we invited teachers to join our courses, and they got problems once we changed the topics, and during the time when the HPV vaccination was implemented in Germany, we used it as an example. And well, the teachers that just understood what it needs to make good decisions, once this campaign for the vaccination came up, they actually couldn't think about that even such a situation, I can decide to get vaccinated or not. that was really hard thing that we would allow students to make such choices. So there is a difference between I understand what methods it needs, and on the other side, depending on the topic, am I really prepared to allow informed choices in students? Once when I'm convinced, I could decide against such a campaign. And that is quite a challenge. It's not just the to teach to prepare the teachers to teach a curriculum. It needs quite a lot to address their attitudes as well.
One thing I was wondering about EBM school is it seemed like it was very resource intensive, being taught by people who were trained in evidence-based medicine. I was wondering if that had to do with you're not pursuing it further, or there were other reasons why EBM schools hasn't been disseminated more widely or followed up on.
Well, actually, the major problem is that we never got any funding to continue, and like we have some teachers, they still teach it, and but it's impossible to get it into the system without funding.
Thanks. Declan, do you want to go next?
Yeah, kind of the scale up. So from the START initiative, we are having conversations with a number of different countries who want to bring it there, and that scale up which was really helpful. Internally, we're trying really hard to scale up, and again, trying to target the schools and their teachers. We found a vehicle recently, again, working with teachers and what their needs are, and sometimes what the hook might be to get access for some of these programs into the schools. And we're running a meet, and lots of us have access to these kind of expertise. We are running a Meet the Scientist initiative, which is a weekly or fortnightly initiative targeting primary schools. So, for example, a half-hour webinar where someone comes along to meet the data scientist, i.e. statistician, or meet the engineer, meet the doctor, meet the marine biologist, etc. And they've been really good. And some of those we've had, close to 3,000 kids taking part in some of these webinars, and the teachers are using those as a teaching tool also. But it helps us in terms of scalability because it gives us an opportunity to engage with those students, and particularly those teachers, and mention the initiative and try to have those conversations and bring those in. I do think it comes down again to more substantial scalability, as a number of people have mentioned, comes down to funding and funders. And perhaps I might say, I think it's easy for us to say funders, but some opportunities we've had that have been opened for funding, the peer reviewer comments, and that's sometimes people like us who are reviewing these grants, don't perhaps see I think there's often a very strong tendency for people to want evidence of behavioral changes or change in actual health outcome for interventions that are targeting young children, and the appropriateness of that, and really needs to be questioned. And I think we as peer reviewer community, some people are need to ask ourselves questions there, I think.
I was wondering about START, that the sort of like science fair type projects are very popular, and they seem to work really well, but they're dependent on somebody external or somebody like you with funding to manage them, and there's a tendency that they'll sort of fade out once that's gone. And so I started wondering how you see the sustainability of START, and if you have ideas about is it sustainable? Are you managing to make it less dependent on your team, which has been very good at it?
Yeah, are we managing to make it less dependent? Probably no. I would like to think we're doing a better job in terms of providing better quality resources. So last year we developed an online game to targeting children to help them understand the concept of fair comparisons, and where they have to pick football players and what are the factors they're using and how that compares with randomization, for example. So we're trying to develop the resources. So the sustainability would come from the START initiative by having the resources to such a quality and point that actually the teachers can engage with them themselves and don't need support externally. So that's the sustainability model that we'll be looking at. However, and that's for the teachers. The children tell us that the best part of the START competition, the START initiative, is the 3 top entries are invited to come to the university for a day of workshops related to science. That bus trip, that day off, that day with their colleagues, and is what's really valuable to them. So it's funny, the motivations can be very different. So, but we can work harder we can do better, and I think we're doing okay. But we need to look at if sustainability would be high quality resources that are there, that are really deeply teacher and children informed in their development and availability. Again, that takes some funding, but that would be the model, the pathway, Andy, to sustainability of START.
Thanks, Declan. Sarah, do you want to go?
Yeah. So regarding implementation challenges for the secondary school resources, we're just concluding the trials now, so we haven't actually been attempting to disseminate them and seeing if they're being picked up in the way that the primary school resources have been picked up by other countries. But we've been thinking about implementation from the beginning, and when we did a context analysis in the beginning of the development phase, we were trying to also explore barriers to implementation later and take those on board early before we started development. So the resources are developed with the idea of making them implementable in mind. So they're designed to be adapted and translated by people in other settings. And for instance, one of the modes of the lessons are created in Google Slides, and that's a format that teachers can also adapt themselves individually. So we were thinking of national adaptations like translations to other languages, but also the lessons can be tailored by teachers, and I think that helps implementation into different kinds of classrooms and people with different sorts of teaching contexts. And people have been talking about how to train teachers and what sort of model to base teacher training on, and we are also thinking about this. I think one of the ways one can do that is to have a resource that is a sort of standalone, like Lila said, to have something where there's very little teacher preparation necessary. And the primary school resources that we developed fit that kind of model because they're a comic book that the kids can read even if the teacher is gone out of the room. But the secondary school resources require a teacher facilitator, and so what we did is we added a teacher training module to the resources. And for the trial, we asked the teachers that participated in the pilot to teach the trial teachers. So we took ourselves out of the equation for the trial to see if that was a feasible way of making the resources independent of us, so that we didn't have to always be there if they were going to be implemented by somebody. And we don't know yet how that worked because our evaluation isn't finished. But I think as far as getting them into curriculums, that's a really big challenge. And our experience has been throughout all of our projects. I would say our experience has been that once the teachers and the students use the resources, they get excited and they've been motivated. And our main barrier really are the gatekeepers that are deciding what goes into the curriculum. And so I think in the future we need to think more about those people as collaborators and target audiences. How can we communicate better with people who are deciding what's in the curriculum, and we've involved those groups in development. So that's maybe a first step, is to invite them into the projects and to help design the resources. Yeah.
Thanks. Pamela?
I'm going to echo with what a lot of people have already said, particularly Alan and Sarah. I know you were talking about plugging into existing curricula and talking with teachers. What do they have to do? That's where we focus our attention. So how do our resources align with the grade levels and core subjects that teachers already have to teach? And how can we make our intervention fit what they're already doing? All of our resources we have aligned both to the Common Core standards and state standards, and we identify how it meets what teachers are already being asked to do, required to do, being assessed and evaluated on. And that certainly helps. Though when we find school districts that have a predetermined curriculum and tell teachers you got to teach this and this and this, it's much harder, right? And I think, Sarah, you were talking to this point as well. So when we talk with those teachers, how can we navigate? How can we fit in? A lot of times, and I was one of those teachers a few years back, I would squeeze it in because I knew it was important, and I would find a way. But it's often when you're at that level up to those teachers to like make that jump. And it's just, and I still say we because I still am an educator at heart. We still have so much on our plate that you have to find a way to fit it in with what is already required in that existing curriculum. For our resources at the News Literacy Project, News Literacy as a entity is picking up steam as a requirement for graduation in the United States. So far, Illinois is the only state that requires a course for graduation, but I think 14 have policies to encourage media literacy. And some states like Colorado have passed laws to incorporate media literacy into their education standards. So it's coming, that change is coming, and our resources will fit, that change.
Thanks. Tammy, I think we have time for maybe one, maybe two questions.
Oh, don't make me have to pick one. There's quite a few I'd like to cover. Okay. Perhaps for this this first question, we could probably answer very quickly because I think I know the answer to all of it. Maybe if everyone unmutes themselves to answer it. Did you need ethical approval and did you have funding? You want to say, did anybody not need ethics? I have to do it that way. No, so everybody had ethics? Yeah, so everyone had ethical approval. Did anybody not have funding? I know Layla's trial, we didn't have funding. I think all the others had smallish grants, but ongoing funding is the big issue. Pamela, did you?
Mine wasn't a study, like it's not a control trial, so we didn't have the ethical, we didn't have to go to the board, to get approval. So, but we did have some.
Yeah, okay, thank you. So I think we dealt with that one quickly. The next question is about those who involve teachers, the teachers in doing the teaching, how you motivated or incentivized them. Any quick comments on getting teachers involved? Did anybody have resources to incentivize teachers? Reward them in any way?
We didn't. We didn't. There was no monetary incentive for teachers in our work. I think how we've motivated teachers to work with this, I think, has been talking to a small number of teachers to identify what is it that makes this most relevant and what do they think might be the best way for us to present this and integrate this work in the schools. So teachers telling us, well, look, instead of presenting this, for example, to children, you present it to teachers, and some of the things you need to consider there is mapping, for example, the initiatives or the work against that particular primary school curriculum, and them supporting that mapping, because they're the people that can often see, where who are the experts in seeing that link between a particular initiative and how it links with the primary school curriculum, and then how that curriculum could be translated on the ground in the classrooms. And once that's been done, we find that, I think somebody's mentioned earlier on, that teachers, do see that motivation. If they see that benefit for them or their students, we have found that it's possible to engage with and motivate teachers.
Okay, thanks, Declan. Any other comments about incentivizing teachers? Pamela, you had a hand up?
Yeah, we incentivize teachers because our resources are free and they're really great. So our teachers want to use them, because a lot of times they have to pay for equivalent types of resources. So it's a really great, that's our incentive. We don't pay teachers to use our materials, though I want to say, I think a couple of times we might have offered like an Amazon $50 or $100 gift card for participating in surveys afterwards to get more information. But I don't think we do that all the time. So if anyone's listening, some people get paid, some people don't. But no, our resources are free, and that's really the big hook for us.
Okay, thank you. And Alan, your hands up.
Yeah, I think in something similar to what Pamela's just said, I think what sort of motivated our teachers was the fact that once they started looking at the materials and found them relevant, they were highly motivated to use them, because they were not only speaking to the students they were teaching, they were speaking to the teachers themselves. And also, I think that the comic book was very exciting for the students. And once the students were really excited to be in these lessons, the teachers fed up that excitement as well. So they were able to be motivated to teach these lessons.
Thanks, Sarah?
Yeah, I just wanted to add that all of our resources are also free, if that's a way of motivating teachers. In addition, the secondary school resources are designed to work offline. And so the teachers were able to use them in the event of no internet connection, which often happens in African countries. And they were designed to be used on a mobile phone. So even if the electricity was gone, the teachers had the one version that was designed for use on a phone. So I think that might have been an incentivizing factor. But I agree with Alan, is that our experience has been that once the teachers see the content, they experience it as relevant for themselves as well, not just for teaching the students.
Thanks, Sarah. Andy, can I have one comment and then one question?
Yes, you can. But while you're making the comment, I'm going to ask Tom to launch the poll so we can get some feedback from people, and they can be filling that in while you go ahead.
Sure. So the one comment is that all these projects are great. Wouldn't it be great if we unified in some way and had them all available, at least online or somehow in a united way? And David's very kindly posted out that there's the Teaching Evidence-Based Healthcare resource website is in the Q&A. So I guess to comment that, yes, we're aware that uniting on this front would be a good thing. I guess there's roundtables one step towards doing that. So that's just a comment. While folk are doing the poll, there's one final question. I'm not sure if anyone's got any comments or responses to this, but has anyone from the work they've done developed any insights into cognitive models or frameworks about how children mature with these concepts over time? And are there sort of threshold ages for certain concepts? If anyone wants to tackle that one in the 60 seconds remaining.
No, I can say something.
Good question. I think that's an important question.
There is some work by cognitive or educational psychologists that show that, in fact, some of these concepts can be learned by infants. They can start figuring out some of these concepts. We found out for the primary school that about half of the concepts that we've been focusing on could be learned and understood by primary school children. Some of them are more difficult. And when we surveyed Norwegians, Norwegian adults, most understand about 6 of the concepts, and then it's sort of halfway for a bunch of them. And then there's some that most adults don't understand. So it is possible to, there is a range of difficulty, and it is possible to actually start teaching this at a very, very young age.
Thanks, Andy. Just to comment that folk have asked about where the recording will be, and I'm assuming it'll be on the Informed Health Choices website in the same location as the summary of.
Yeah, thanks. I'll send a message to everybody once it's posted, letting people know where it can be found.
Thank you.
So we can take a quick look at the poll. So most people got what they were hoping for, or for the most part did. A few people were disappointed. Most people would be interested in more webinars like this. And most people thought the format, liked the format. So I want to give my deep appreciation to all of the discussants. It's been a great discussion. I've enjoyed it. Thank you all very much. And to all the attendees, I'm sorry that we couldn't engage everybody verbally in the discussion, but we appreciate the questions and everybody taking time to join us today. So thanks, everybody.